morning. My name is John Forbes. I'm the program coordinator at Charles Drew University Oasis Clinic storefront program. We'd like to thank you guys for the opportunity to let us present our data and our program, our services, and what we do for the community in South Los Angeles. Pretty much today, learning objectives is to provide an overview of the HIV services at MLK Hospital Outpatient and Charles Drew University campus. To discuss the outreach and referral resources for the HIV testing program, outline an effective outreach strategies, provide a brief overview of the epidemiology of the HIV in Spot 6, explain the HIV testing data, study protocol, discuss the results of data analysis, and explore the next steps. So at Charles Drew University, we have the university. Next to the university, we have Oasis Clinic, which Oasis Clinic is part of MLK, but it's not in the hospital. It's right across the street from the hospital. We also have an APLA dental clinic, APLA food bank. We have Spectrum, which we provide mental health services, case management, support groups, both in English and Spanish. We have a benefit specialist, and right across the street from us is MLK Hospital, which was opened last year. In the MLK Hospital, they don't refer any outpatient out. All the services are in-house. That's in the new hospital. So we pretty much a one-stop program for someone. If someone needs medical care, we have Oasis. Someone needs mental health, we have Spectrum, and we also have Oasis. We have the dental clinic, all within walking distance. So pretty much a full spectrum of the HIV services. Oasis Clinic is an outpatient medical care. We only focus on HIV care. That's our specialty. Like I mentioned, we have a dental clinic, which is run by APLA, the food bank, also by APLA. We have mental health services by Charles Drew University. We have a PrEP navigator, clinical service at CDU Oasis Clinic. We have PEP and PrEP now implemented. We also have case management, which the MCC, the medical care coordinators team. They're based inside the clinic of Oasis. We also provide housing referrals through APLA. We have therapy groups, linkage to medical care. I think we're very unique because if someone is identified positive or someone wants to be linked back into care, we do not turn no one away. Without identification, undocumented, they're seen the same day. And we do provide preferential treatment. They do not wait in the waiting area. They get walked back into the clinic, and they immediately see a nurse and a provider. So we do not make anyone wait who's going back into care or is newly diagnosed. And we do provide HIV testing and counseling services. So my next slide. Back in 2009, when I took over the program, we were struggling because we were storefront. And to get people to come and test into a storefront is a little challenging. We're not a mobile unit that we can move throughout the community and just test multiple people. So when I took over the program, I said, where am I going to start? We've been struggling with numbers. So I went to the public health data source, the HARS, and I looked at where people were living with HIV were being identified throughout the county. As we can see in the red spots, SPA, and then I looked at South LA. I looked at Inglewood, Gardena, looked at Southgate, Huntington Park. I looked at Willowbrook, Watts, Compton, South Compton. So I kind of got an idea where people were being identified, people living with HIV were being identified. So I said, this has to be my target area as far as zip goes, what's going on in the community. I also had a dialogue with a lot of our patients. What do you do? Establish relationships. That's the main source. I think the rich part of our program is that we have established relationships with patients that they do provide us with information. As far as venues, where you should go, here's what's going on in the community. So on my next slide, outreach. Pretty much we're all professionals in this room. We know what outreach is. What outreach is to meet the people outside the office where they are, in the community. In South Los Angeles, I found out that pushing testing on someone wasn't the key factor. There's something lacking. Why should I test? I'm okay. There's nothing going on. So I've kind of brainstormed, and I said, let me show you the stats, what's going on in the community when I would present, and people were being more receptive. So I kind of found out that educating the community worked first, so they can get enriched. What does my status mean to me, being negative? So within our community, I found out that educating the community was first. Going into venues, going into agencies, going to the projects, Nicholson Gardens, the projects, the Pueblos. That's what worked within the community. Educating the people, this is what's going on. And I start fostering relationships with a lot of agencies, with a lot of clients. One of our, I think, strengths in the program is our team. I have a Black MSM in our team, and I also have a Latino MSM. Myself being Black Hispanic, I can relate to both cultures. Growing up in a household with Black and Latino, I can relate to both cultures. The approach is totally different. The approach of a young Black male living in the projects, being an MSM, struggling with that, struggling with being bullied, being picked on. It's different circumstances than living in a Latino where the culture is totally different. You know, so within the Black and the Latino community, there's a huge struggle. And the way I've been able to kind of ease through it has been through education. And the message should be a specific target to the population we serve. You know, the value systems are different. Being able to relate culturally, I think, makes a big difference in the work that we do. And so my next slide. At Charles Drew University, we have 2 testing programs. We have the mobile van, and we have the storefront. Like I say, people will walk in. We also receive community referrals from other agencies, referrals from jail, patient referrals, court-mandated testing, and community outreach, where we go out and do multiple health fairs, let the community know, hey, here's where we are, here's what we do. If you need us, you know, we'll come out and just make the community aware. The stigma in South LA is still pretty huge. The stigma within the Latino community is still pretty huge. There's still a whole lot of work to be done. So based on the data that my colleague is going to present, I get asked a lot, how do you capture all these positives? What do you do different? What's going on? Well, to start, Oasis Clinic was the first HIV clinic in South Los Angeles to provide HIV services since 1984. Our medical director is Dr. Wilbur Jordan. So we've been around. I wouldn't take all that credit, so let's just start. What do we do? I can give you some of the, we work with Black and Latino MSMs and their partners. What happens at the clinic? I can tell you something that goes on at the clinic. Most of our patients probably seen the latest movies that I haven't gotten a chance to see. Dr. Jordan plays movies for them, feeds them. We have churches that come out twice a week, feed our patients. Some of our patients don't have medical appointments, but they just come every day just to hang around the clinic. And that's how we start fostering and building relationships with the youth. That's the only hot meal he feels they might get during the whole day. He can walk in and there's no food, he'll order pizza, and we just have like a gathering at our clinic. Commercial sex workers. I have fostered a relationship with commercial sex workers, I said, for the past 5 years, where some of them were court mandated by soliciting. Some of them now just come on a regular basis. And by fostering relationships, they would not allow anyone to test them but me. I provide them condoms, I provide them lube, female condoms. What do you need? And it's just about building relationships. I'm not trying to stop your behavior, but I want to make it safer. By fostering these relationships, I've been able to work with pimps. How I've been able to work with pimps, being able to get connected through the ladies, being able to have a dialogue with this gentleman, educating them. How can I make your product safer? How can I make your product sell better? This is what's going on. This is what I can do for you. Now it's to the point that they bring the females because they want to know their status prior than putting them in the street. Swinger groups. I work with 2 swinger groups currently. How was I able to capture and get into the population? Someone tests positive. That particular person linked me to the producer, to the promoter, so I might say. I met with the promoter, education one more time. This is how your group can be safer. Your group tests every 3 months. You and I have a color code, you and I have a code. Now you know every 3 months this is the only way they can participate. Oh yeah, here's what I'm gonna do for you, make your group safer. I have a group of females who are 200 pounds and above. They meet every Friday at different venues. I have a group of heterosexuals where a male have to bring a female can go by herself, but a male cannot attend by themselves. I've been able to tap into this type of population, and I have identified quite a few positives through them. Community clinics in Watts, Compton, and Willowbrook. A lot of them don't provide HIV testing. If they do, and they do identify someone testing, they refer them to us so we can link them into care. I work with halfway houses also. Last but not least, churches. I have not had a struggle working with the church. I probably have 10 different presentations for churches because I tailor the presentation according to what they want. It's not about talking about sex, it's not talking about using a condom, it's about education. I found that they're more receptive when you just educate me. I don't want to know about sexual behavior. We don't want to know about this. We just want you to educate the youth, work with the congregation. So myself personally, when it comes to the church, I've never had a struggle. So these are just some of the logistics, how I've been able to capture the high positivity rate that we have in South Los Angeles. Next, I would turn it over to my colleague, he would do a breakdown of the data, and David Lee.
Good morning. I'm having some memories here, being back at HIV Commission. I served on the Seattle Planning Council for many years, and also when I was in Houston, Texas, served on their planning council. So this feels like I'm at home again. So what I'm going to do is kind of describe to you what the data looks like, what the people who come to our clinic to get tested, what they look like, and some of the risk factors that we've identified. John gave you an overview of where these people come from, how his team has been successful in capturing a lot of different populations in South Central Los Angeles. So this is just a map of all the spas. Everybody in this room is probably familiar with this. We are right here in Spa 6. We're actually sandwiched in between Watts and Compton in the unincorporated city of, well, I guess it's not a city, but Willowbrook. So, just a snapshot of what Spa 6 looks like. As you can see right here, oops. This is South Los Angeles, Spa 6. Number 4 in the number of cases in 2014. I won't dwell on that because I have a feeling everybody's familiar with that. These are the rates. We're the second highest. Spa 6 is the second highest rate of HIV diagnoses in 2013, right here. So basically, we went to our IRB and said, hey, we want to do an analysis of our HIV testing data. This is basically a descriptive analysis. We wanted to look at the demographics of people who test positive at our site, do a descriptive analysis of those testing positive and those testing negative, and then look at some of the risk factors involved in those HIV positive tests. The study design was a retrospective cohort study design, secondary data analysis of de-identified confidential HIV testing data. Our data was collected between January 2013 through September 2015. Data, when a person comes in to test, the counselor fills out this form, which a lot of people may be familiar with. This is the form used by most of all of the DHSP-funded testing sites in the county. So a summary of what we found during the analysis period, we tested 5,478 individuals. 247 HIV positive test results. So that's a seropositivity percentage of about 4.5%. We broke it down by age to see what that looked like. These are the same age groups that the LA County Department of Public Health uses for their reporting. Most of our folks that are tested are in the age range of 20, 29, 30, 39. Most of the positive test results are at the other end of the spectrum as far as the percentages. This is what it looks like graphically. Again, we test a lot of people the majority of the people we test during the time period are in these two groups, and the percentage of positives are higher among these groups. We looked at it by gender. Although the total number of transgender individuals tested at our site are low, you can see that the percentage of positives are highest among this group, followed by males. Females are well represented in the total number tested during this period. We looked at it by race and ethnicity. Blacks have the highest percentages of positives, followed by whites. Blacks and Latinos represent the majority of those tested at our site. Looked at it by HIV positive test result by gender, race, ethnicity. We see that blacks and Latinos represent the highest percentage of positive males. Black women represent the highest percentage among females. With small numbers, blacks and Latino represent the highest percentage of positives among transgenders. This is just a snapshot of HIV positive result for women by race, and as you can see again, black women represent the largest number of those testing positive among women during our time period. We looked at seropositivity percentages by sexual orientation. These include men and women in these groups. Lesbian, gay, bisexual, queer individuals represent the highest percentage of positives at 9.3%. Again, these groups can include men, women, and transgenders. But we did separate it out by men who have sex with other men. And we see a positive percentage of about 11.1%. HIV positive test result by sexual orientation and race and ethnicity. These groups include men and women. When we further explore by these characteristics, we see the highest percentages for blacks and Latinos in all sexual orientation categories, right here. So just a little comment at this point. It just shows that the HIV testing and counseling team has been successful in doing outreaching into the population of the folks that actually live in our neighborhood, which is almost half and half blacks and Latinos. So they've been really successful in reaching these populations. This is just what shows you graphically the near equal distribution of HIV positive results between blacks and Latinos at our site. The blue is black and the red are Latino. So when we look at risk profiles, some of the questions that are on that Form A that I showed earlier, people are asked information about, do you have permanent housing? Or are you living in a car, which is considered no permanent housing? And we looked at those results, and we see that we have a higher percentage of positives among people without permanent housing compared to the people who are permanently housed. Although the number total of people tested have permanent housing. People are also asked about drug and alcohol, drug use and IV drug use. So this is what it looks like. We didn't see any strong associations between HIV test results and drug use. We did see high percentage of people who tested positive who indicated either meth, crack, or cocaine use. Those percentages of the positives were higher. The percentages of positives among those who indicated heroin use and shared intravenous drug use are less than those that did not indicate the use. Positive results are slightly higher for IDUs. However, there is not a strong association between test results and individual risk categories here. I think some slides didn't make it into the presentation here, but it might have been that last one I sent at 6 o'clock this morning that didn't get received. So just briefly, I'll tell you what. We also looked at sexual risk, which is not included here. Individuals who come in for testing are asked, did you use a condom while having vaginal or anal sex with a male in the past 12 months? The percentage of those who responded yes, the percentage of positive test results of those who responded yes is 6.9%, just slightly higher than those who said no. We asked the question, did you have vaginal anal sex with a male injection drug user in the past 12 months? Those testing positive those who said yes and also tested positive, the percentage was 20%. The percentage of positives was 20% compared to those who said no at 5.2%. We asked the question, did you have vaginal or anal sex with an HIV positive male in the past 12 months? The ratio, the percentage of those who testing positive was 15.3% to 4.7%. And lastly, on the sexual risk, we asked the client, did you have vaginal or anal sex with an HIV positive female in the past 12 months? Those who responded yes and tested positive, the percentage was higher, 10.7% compared to about 5.2%. Okay, so that brings us to our next steps. What we did, again, was just a descriptive analysis of our data and trying to see what some of the risk categories might be for those that are testing positive. But what we would like to do in the future, and we have to go back to our IRB and ask for approval, is to have this as an ongoing analysis for our testing program. We did a snapshot again between January 2013 through September 2015. But since this program is ongoing, one of the things we'd like to do is just have this analysis to be ongoing also. We would also like to go back and find baseline laboratory data for our positives to find out exactly where were these people in the disease process when they first tested positive. Are people further along in the disease process in our neighborhood, or are they new in the disease process when they are diagnosed with HIV? That's something that we would also like to find out. And one of the things that is done for someone who tests positive is they get baseline viral load and CD4 cell labs, so that information is out there. We'd like to do a more extensive data analyses, such as maybe some odds ratios to explore the presence of HIV in specific groups that tested our site. Some people in the audience might have some ideas about others, so we're happy to hear. So just to summarize what I've gone through, HIV seropositivity percentages are high among men testing at the Charles Drew University storefront site. HIV seropositivity percentages are high among MSM testing at CDU. HIV seropositivity percentages are high among American Indians, Alaska Natives that test at Charles Drew University. HIV seropositivity percentages are high among transsexuals testing at CDU. Black and Latino represent the highest percentages among men testing positive at Charles Drew University. Black women represent the highest percentages among women testing positive at Charles R. Drew University. And the other is that through our outreach efforts, our program has been very successful at reaching underserved populations in South Central Los Angeles. And I'll finish just with my acknowledgements. Dr. Jordan is the director of our HIV testing program. Magna Shaheen and Dulcie Kerma assisted with the data analyses for this presentation today. And I also want to thank Eric Houston, Gregory Victorian, and Ryan Coffrin for graciously reviewing our presentation today.